Okay, so enough with the introductions. This is what you really came here for, not to hear me talk. Is I'm going to bring up my panel, who I'm really happy to have come up here. Nancy Daniels is our palliative care person, and we're going to have you come up. Mary Torres is going to speak on hospice. And Janet Hanker, if you guys have been to events, I think it was a year or two ago, Janet was here, and I've invited her back. Janet knows a lot about this, and I'm really thrilled to have all three of them here. Okay, so before we actually start, I'm going to have each of them talk about, just explain who they are, why they are experienced to be here, because I like to have experts in the field when I bring people to you. So they're going to share who they are, what they do, and why they're a bit passionate about it. So Nancy, let's have you start, please.
Okay, Nancy Daniel. I'm a nurse, I'm a registered nurse, and I've been working in hospice and palliative care for most of my nursing career, which is well over 40 years now, and very passionate about it. I'm thrilled to be here today. I got into this when I was in nursing school. My mother came down with a terrible cancer, and she had been a nurse. She didn't want me to quit nursing school to come and take care of her. I was in Boston, she was in Ohio. And so, at any rate, she had a horrible death in the hospital. She suffered greatly. This was in 1977, when things were very different. We didn't medicate pain very well. From then on, I was very interested in helping to take care of people at end of life, and really spent my career doing that. In, 25 years later, my father died in my arms, in my home on hospice, and very comfortable. So just in my lifetime, in my career, I've seen how far we've come in this arena. So you have so many options, so many choices. I'm just so glad there's people here today to learn about it, so that you're, like Christy said earlier, so you're not making decisions in a crisis. This enables you to kind of look ahead a bit.
Thank you, Nancy. Mary?
So I have a master's degree in social work. I actually have my bachelor's degree in social work, went to San Diego State, and then I went to Long Beach State for my master's degree in social work with an emphasis in gerontology. I have been working in the field for about 37 years. My career led me from emergency room to acute care hospitals and nursing home rehab. And I've always done home health and hospice kind of like on the side for some extra per diem money. But there was a time, and I'll probably go on later on and tell my story and really why I went into hospice and just stayed focused on hospice. But I can tell you one thing is that the start of my career, I thought I was going to be in the hospital. Well, actually, my mother really wanted me to be, she was a nurse, and I had a dad who was a physician, a PA. And I grew up all in the medical field. But I really wanted to be a beautician. But my mother, being the fact of who she was, she didn't come to this country because she wanted to raise a daughter who was going to be a beautician. She wanted to raise a daughter who was going to be independent and educated. So she found a job for me in social work, and then I liked the fact that she was dressed up in a suit and all she did was love and talk to people. So my career led me to really get into this field because I love people, but most of all, I love elderly people. Do you guys remember that doll, Mrs. Beasley?
Yes.
Mrs. Beasley, she's still my favorite doll. Well, I finally realized I really have a heart and a calling for elderly people and helping them transition from the hospital to end of life and where they are now. And later on, I will probably tell you more of my story and why I just decided to stay focused on hospice and home health. But my career led me to, I have all experiences and education of all gamuts of the hospital to home, what's needed. I mean, my brain is, when every time I sit with a family, my brain is like, whoo, because I have so much knowledge in my head that I want to share. So that is why I decided to go into social work. My passion, if I didn't have to put a kid through college, I would just be doing this for free. Really, I love elderly people, to the point that my bosses tell me, you know, you can't keep giving me your phone number because you're not going to get paid for that visit. I'm like, oh, it's okay, because in 2 or 3 years, 4 years down the road, they're going to call me and they're going to need hospice, or they're going to need me to direct them to a private duty person, or they're going to need me to tell that social worker at the hospital, no, you can't kick that person out of the hospital because they have no one to take care of them. So my passion is seniors, leave it to Mrs. Beasley, but my heart is for elderly people and helping them. So that's why I majored in social work.
Thank you, Mary. Janet?
I'm Janet Hager, and I came to this end-of-life arena really for 3 reasons. Number one, I'm the daughter and wife of veterinarians, and so my entire life I've been exposed to the compassionate end that euthanasia brings. I am a physical therapist and spent most of my career working in geriatric rehab. So I had long relationships with my patients, and many of them were in horrible medical situations at the end of their life, and would tell me, because I'd become a confidant, for them, they would tell me, I'm exhausted, I just want to die. And so in my head I thought, we treat our animals better in this world than we treat our fellow humans at the end of their life. So that stuck with me for a long time, and in 2013 my husband David was diagnosed with pancreatic cancer, and he was lucky, he lived for 6 years with that disease, but at the end, California's law for medical aid in dying had gone into place, so he obtained the medication. I saw the quality of his life improve and his anxiety go down because he knew he had control at the end of his life. For whatever reason, one night he went to bed and the next day he was in a coma, so he didn't utilize the medication. And for the next 6 days he was in a coma, and I was pumping him full of morphine and Ativan at increasing doses, decreasing intervals, and I promised him that I would advocate to expand California's law. It's much too restrictive. So out of my grief came advocacy, and I joined the Hemlock Society. I'm on the board of directors. I've been a past president. I'm currently the treasurer. We're an educational organization that educates on all end-of-life issues. And from that, I found other people that felt passionate that our law is much too restrictive, so we formed a nonprofit called A Better Exit, and we're working with Senator Blake Spear to expand medical aid in dying in California.
Thank you, Janet. All right, so we're going to start with Nancy and talk about palliative care. Nancy, what's the biggest misconception people have about palliative care, and how is it different from hospice?
It's a big question. And I put together several slides. Okay. It's a very big question, and I put together several slides, I think 4 of them regarding this, and I hope I can clarify this for you. Please know, if you're not familiar with palliative care, you're not alone. Palliative care is a relatively new medical specialty, in fact, it was 2006 when board certification became available for physicians to train in hospice and palliative care and become board certified. So it's relatively new. And even physicians who were trained prior to that are not that familiar with it. Many people are not. Nurses may not be. So, but it's up and coming, and it's very important. So, and it's not hospice. If I could get the first slide. There we go. This is really the big picture, okay? So, and it speaks to all of palliative care. So you can see hospice is there at the very end. At the beginning is diagnosis of serious or terminal illness. That's when palliative care can begin. It can run alongside aggressive treatment, even curative treatment or attempts at curative treatment, and palliative treatment as well. And by palliative treatment, I mean maybe a fourth or fifth line chemotherapy when we know we're not going to cure it, but we're trying to keep it at bay for a while. All throughout that palliative care is available to people. And then when there is no more treatment available that's effective, or when an individual decides, I know I could keep doing this, but I'd just rather not, I'm going to let nature take its course, hospice is available. When it's determined that they have about 6 months prognosis, okay? And so hospice is a form of palliative care, but all palliative care is not hospice. Palliative care simply means to lessen, and their aim is to lessen, improve, manage the symptoms of serious illness. And to do that by looking at the whole person and family, and looking at their emotional as well as the physical, emotional and spiritual care. All right. So, in a nutshell, that's palliative care. But we'll talk a little bit more about with the next slide what it is, how it's different from hospice. Okay. So palliative care is delivered in a number of different ways. Many people first come to hear about it because of a hospital consult. Just like you might go to the hospital because you had a heart attack and get admitted, fairly soon a cardiologist will show up at your bedside because the doctor in charge has asked for a cardiology consult. Same holds true when someone is diagnosed with a serious life-threatening illness. The doctor may order a palliative care consult. And when that happens, usually a team of people arrive at the individual's hospital bed with usually a nurse, a physician, and a social worker. And I was part of a team like that for 6 years at one of our local hospitals. And they actually invite a family member as well, usually a spouse or a child or anyone that the patient would like to have present, and spend a whole hour talking about that individual, the diagnosis, and sort of what to expect from here. Okay. It also, palliative care is also delivered in a clinic setting. So once that person goes home, it's not unusual that they might be followed up in a clinic. And sometimes that's their first experience with palliative care, is that their primary care provider might refer them to a palliative care physician, or the oncologist may. And we're really lucky here in San Diego with Sharp and UCSD and Kaiser and Scripps. They all have great palliative care programs. And when you go to see a palliative care physician in a clinic like that, again, there's a team of people that see you. It's a team sport. And then there's also home-based palliative care, and I work in that a bit now. Home-based palliative care occurs usually when the individual is just a little further along in their illness, exhausted, maybe from going to physicians' offices or perhaps going for chemo every week or every other week. It's getting harder to go in and see their physicians, and so palliative care can come to them at home. But it's still really like a physician's office visit. And when you think of palliative care, I want you to think of that. It's not a big inclusive program as hospice is. It's really treated like a physician's office visit. It's reimbursed that way, so it's covered under your insurance, just like if you saw any other specialist, a dermatologist or a neurologist. If you're with an Advantage plan or an HMO, they may be contracted with specific palliative care programs, okay? The hours are like normal business hours, like a physician's office, and you can't get an appointment today. generally. It's going to be 2 weeks away or perhaps longer. They do not provide supplies or medical equipment, okay? In fact, they don't even order those things. That goes through your primary care physician, but they can help coordinate that with them. The team usually includes, and every palliative care program is a little different, but generally they include a physician, nurse practitioner, registered nurse or LVN, and a spiritual counselor and a social worker, okay? One thing that makes palliative care different, we have so many specialists now, and a lot of times they're not talking to one another. You may have noticed that. So they try to order the same meds for you or whatever. But palliative care really works at helping to coordinate that. So every time I go in and evaluate a patient or admit them onto palliative care, the note that I generate goes off to whoever referred that individual, and then also to their primary care provider or any other physician that the patient requests that I do. And that happens with the social worker and also with the physician, okay? So that's palliative care. Hospice is a much more robust program, and I'm not going to speak in a lot of detail. I know Mary will talk more about that, but hospice is a benefit under Medicare. It's a service. It's covered at 100% under Medicare and by most insurances. It includes all necessary equipment for caring for that individual wherever they are, at home or in assisted living, wherever. Also that covers medical supplies, all medications related to the terminal diagnosis, okay? It involves a team of people that are much more present than with palliative care. It's much more, like I said, much more inclusive, robust program. MD, nurse practitioners, RN, case managers, home health aides who actually come in and help with bathing or grooming or changing linens or all sorts of care. Nurses in hospice do a lot of hands-on care, very high touch. Social workers and spiritual counselors, as well as volunteers, and volunteers are a big part of hospice. And they visit much more often. In palliative care, generally there's a visit every month by the nurse practitioner. The social worker may visit 2 or 3 times in the course that the individual's on palliative care, okay? Spiritual counselor, it's really more up to the client, the patient. Hospice is 24 hours a day. If you're on palliative care and you call at 2 in the morning, you'll most likely be, if you get someone, you'll be guided to an emergency room or urgent care, okay? With hospice, they're right there for you, and they do send people out in the middle of the night to see you. They also provide grief counseling for family and friends, both pre and post death. So just remember, hospice is a form of palliative care, but not all palliative care is hospice, okay? Myths about palliative care and hospice. Many people think palliative care is the same as hospice, and we get that same kind of frightened look when somebody says, you're from palliative care. It's not. I think we've clarified that. If you go on palliative care, people think you can no longer see your other physicians. Not true. Everything stays the same when you're on palliative care. You can see anyone you were seeing before. You can still have physical therapy, home health, everything. Nothing changes. When you go on hospice, you have to stop all your regular medicines. Not true, and not true with palliative care either. When you go on hospice, they give you morphine and you die within a few days. Have you heard that? Have you seen that? It happens. And I'll tell you, it doesn't happen because they went on hospice and got some morphine. It happens because we're afraid, and we don't go on hospice until we're actively dying sometimes. There's so much that hospice can do. There's so much palliative care can do to ease suffering, that really, if someone qualifies for hospice, they should go immediately onto hospice, because it just will make their life better, every day a little better. When you go on hospice, you die more quickly. Not true. Studies show that people with the same situation live longer on hospice than not. And hospice is a place to go to die. Not at all. Hospice isn't a place, it's a service. And it comes to you wherever you are. There are some hospice houses here in San Diego County. Sharp has a few. There's one in the North County for Hospice of the North Coast. But those are not places to go, per se. You can only go there if you have symptoms out of control. And once they get things under control, you go back home or wherever you were. Hospice staff can take care of you 24 hours a day. Not true. You're going to need help. You're going to need caregivers if you're planning to age in place even. You may need caregivers, and certainly if you have a terminal illness. Okay. I think that's that.
Okay, so I know that you said it's not immediate, like if you need palliative care, like during your illness or what you find out you have something, when do you reach out for palliative care?
Well, you may get a referral from one of your physicians, and you may not. And you can reach out anytime you have a diagnosis, a serious life-threatening diagnosis. You can reach out for palliative care yourself. And that palliative care company will get in touch with your physicians or your insurance company to make sure they're contracted, or then refer you to someone else that is, if not. But really anytime from time of diagnosis forward. A lot of times people are so, at the beginning they may not, at the time of diagnosis, their head's spinning, they're trying to plan for treatment. But when symptoms are not well controlled, I say, look for palliative care, find palliative care. These people are the experts in pain management, but also in management of confusion, agitation, nausea, vomiting, constipation, all the kind of things that just come with serious illness.
So how does palliative care support the patient and their loved ones, both emotionally, physically, and spiritually?
Because they work as an interdisciplinary team, those issues are all addressed. And having worked in this arena, I'm sure Mary will agree, she probably knows a good deal of medicine, and I know a good deal of social work. You come to share a bit of this and work together, and with the chaplains as well. So it's really, like I said, it's a team sport, and people work to meet that client, patient, wherever they are, and in whatever their setting is, whatever's important to them, help to make that a priority in care.
So you mentioned about a team, and it sounds like it's important to have that team. What does a nurse like yourself play on that team?
Boy, it all depends. Right now, I can tell you, I'm working per diem for a company that does both hospice and palliative care, and I do admissions. So I go out and do the evaluations, meet with the individual, I review all the medical records to see how we can best help them. Is it through palliative care? Is it through hospice? And get them admitted onto that. In palliative care, I field a lot of phone calls from patients at home too that are on palliative care. Regarding, we may have started new treatments with them or new pain management, and just help to coordinate their care.
Can you speak to the goals of care, conversations that help patients maintain their dignity and control?
Definitely. And that's the next slide. This is so important. This is palliative care, okay? The first thing we do in palliative care is try to establish goals of care with the patient and their family, with their family present, if at all possible. And so what they're doing here is clarifying and ensuring a patient's understanding of their diagnosis. That seems simple, but believe me, a lot of people don't really understand what's going on. Prognosis, explaining prognosis. So often I go out to meet and evaluate someone and I say, what has your doctor told you about your prognosis? And they look at me blankly and say, I don't think they know. They haven't said anything. Believe me, if you want to know, they know. And we don't know exactly ever, but we have a good sense of prognosis. And it's so important to, how do you make a plan for anything if you don't know what's coming? So it's important to get a prognosis. And then treatment options. And one option being no treatment. You don't hear that often when you go to see a doctor that is going to provide treatment for you, because, you know, if you go to Midas, they're going to sell you a muffler. And I don't mean that in an uncaring way, it's just what they know. It's what they know and what they think you're there for. So palliative care is not selling anything. They're there to help you make decisions about what is right for you. We discuss your values and wishes. What's important? What makes life worth living? What makes getting up in the morning worth it for you? And when is it not worth it anymore? And I'll tell you, I've talked to, I had a man once tell me if he couldn't play golf every day, he really didn't care to continue. That's the one extreme. And then I used to visit this woman in a nursing home who couldn't even get out of bed by herself at all. She was really bedbound, but she had a window next to her bed. And there was a tree right there, and she was just fascinated by this bird that had built a nest there, and she was watching it raise its children. And some people say, if I can just see the faces of my grandchildren and hear their laughter, that's enough. Everybody's different, okay? And it's important to explore for you what that is, what's important. We also look at people's fears, because sometimes I can quell the fear right away. I can tell you right now, no one needs to be in pain. No one needs to die in pain. We have great pain medications. There's no need to suffer in pain, okay? And if your pain is not managed, seek someone who knows how to manage it, because they're out there, and you don't have to be knocked out most of the time. Okay. And then we help define decisions on medical treatments like CPR, feeding tubes, ventilator assistance, dialysis, future hospitalizations. These are all things that we think we know what they are, but we don't really know in relation to the disease that we have. So it changes things. Of course, if any of us here today were hit by a car out here, we want the paramedics to come and do what they can for us. But if we're really suffering and we have bone metastasis throughout our chest, and we stopped breathing, would we really want someone to come and pound on our chest, knowing that would break the ribs and puncture the lungs, and we wouldn't live anyway? Some of these questions really, these choices that we make, I think we're deciding, do we want to live or not? But we're not. We're deciding, how will we die? What will it look like? Okay? And only people that are knowledgeable about those things are able to show it to you that way. And then we talk about documenting these decisions in an advanced healthcare directive, and then also on what's called a POLST form, that bright kind of pink form you may have seen from your physicians, that talks about those life-sustaining treatments. And then once those goals of care are discussed and sort of decided, and they can change. You you might decide something today that you want different 6 months from now. They can change. But once we do that, we try to then align other medical care with that. And again, communicate that to the other physicians and people involved in the care.
Hey Nancy, one last question, and what's the one thing you wish more families knew or did earlier when facing a serious diagnosis? Do you want that slide first or after you talk?
The only slide left is the movie.
Yep.
No, we're gonna end with the movie. It
Okay.
takes a whole minute, it's not
Okay.
a real movie.
All right, so
But-
answer quickly because we're getting
I will.
short on time.
I wish people would talk to one another, talk to their family, talk to their loved ones openly. Once you get a diagnosis, take your family or your loved one with you. I'll give you one example of a client that I went to evaluate for the hospice or palliative care. I knew going in this lady was hospice appropriate from her medical records. And when I got there, I got to the door, her husband answered the door, and he said, "Oh, okay." And he stepped outside and, next to me on the porch and closed the door behind himself. And he said, "I just want to let you know, she doesn't know you're with hospice, so I don't want you to mention that word, okay?" And I said, "Okay." I said, "Well, it does say that on my badge." And he said, "Oh, she won't look at that." He said, "But we've told her you're just here to help her get a little more care, and we don't want her to give up hope. I'm afraid she'd just give up hope." I said, "Okay, well, if she asks me, I'm going to be direct. I'm not going to lie to her." And he goes, "No, but just don't go in saying you're from hospice, whatever." So I get in, I sit across from her, I describe what palliative care offers, a physician's visit once a month, continue to be able to go to the hospital and to see all her other physicians. She says, "I was in the hospital 4 times this month. It didn't do me any good, and here I am. I'm just as bad." And she said, "I really don't want to do that." And I said, "Okay, there is another program that provides a lot more care in the home." And I described that to her. And I said, "You know, people that choose this are really just tired of it. They know they're not getting better, and they just want the care to come to them. And they want to be comfortable and have as best a time as possible with their loved ones in the time they have left." And she said, "That's me. That's what I want." And I said, "Okay, the name of that program is Hospice." And she said, "That's what I want." And her eyes welled up with tears, and her husband was sitting a bit of ways, and his eyes welled up with tears. And then he came over and put his arm around her, and I said, "You know, hallelujah, because they can talk about it now." Now, they both knew, they just couldn't come together. There's a wonderful book, I brought 2 copies, and they're for free, so take one, whoever gets one, please read it and pass it on. It's called The 4 Things That Matter Most. It's by Ira Byock, he happens to be a hospice physician. But he talks about talking with your loved ones at this time. We need the support of our loved ones more than ever, so not being able to talk is just awful. And those 4 things, I won't spoil the book by telling you. The first one is to say, "I love you." We don't do it enough, especially with people we're with all the time. The second is thank you. Thank you for seeing me through this. Thank you for being my husband. Thank you for being the father of my children. Thank you for whatever. The third one, please forgive me. We carry guilt all the time, and sometimes we don't express it. Please forgive me for whatever. And the 4th one, I forgive you. I forgive you for whatever it was that you may be not been very forgiving about.
Okay, we're moving on to Mary with Hospice. What feelings do people have when considering hospice?
There is a lot of emotions and feelings right from the beginning of the initial, "I'm going to call hospice to come talk to you." I get the opportunity, Nancy and I have worked together for a long time, well, different agencies now, that they call me in and I meet with the families, and I also get, "Please don't mention the word hospice. please use the word comfort care or I'm here to help. It's the fear, the feelings that they have is fear, uncertainty, still hope, like, okay, I'm gonna accept this referral, I'm gonna talk to you, but this is only gonna be temporary, because I'm still hoping that there's gonna be a miracle that's gonna happen. Or I get a lot of sadness, a lot of grief already starting, a lot of relief that, oh my gosh, I'm finally getting help. I really don't want my loved one to have any more pain. Also the anxiety of who is going to pay for hospice, and will you guys provide 24-hour care at home? Financial stress is a lot of the emotions that I get from families. Just a lot of mixed emotion, but in the nutshell over all of it, the family is there and they're devastated. And they just really are at loss of not knowing what to do, guilt, and the big one is, are we making the right decision?
So how do you help people process that grief even before the patient has passed?
So let's look at the stages of grief first. Denial, emotional protection. Anger, as the reality sets in. Bargaining, if only. Depression, deep sadness. Acceptance, sense of peace. To me, well, not to me, grief starts on day one. Grief starts really when the doctor gives you that message, I'm going to have a nurse and a social worker talk to you about hospice. The question was, how do I help them process? The best part of my job is really listening, really offering that support right from day one, really helping them hear and listen to what their goals are. But also being able to manage what is the best outcome and how you can take care of your loved one. Is it hiring help? Is it having a family meeting, coming in so that every family member is involved in taking care of that patient? Processing grief starts from day one because they're still in shock and denial, right? They're still in bargaining. What if I only did this? What if we only did this for a few months and then can we go on home health? Well, what if then we just get physical therapy? We get a lot of that. And the patient could be already bedbound. The anger. I get a lot of spouses sometimes still angry at the family member because, wait, we saved all this money and we still have a cruise coming up in 2 weeks. We're not ready for hospice. What can we do? Depression, lots of ups and downs. But going back to that cruise, the best part about my job is working with my team and saying, can we make that happen? Can we call and maybe make a 2-day cruise or a 3-day cruise out of Ensenada? What can we do to make that life goal, that very last goal or wish that they have, happen? It may be creating a cruise at home and having the family come join in. It may be celebrating that 67th wedding anniversary, where I call in our chaplain and we renew the vows. The funny thing about that one, I have to share this story. The doctor told them they had 3 months to live. Their anniversary was coming up. I kid you not. And I'm not trying to bring hope to anybody. But I go, we need to order a cake. I need flowers. I need a dress. They're like, okay, Mary, why? I go, because they're going to renew their vows. Paid for it all. That was her life goal. Do you not know that after we did that, 6 months later, she bounced back? She bounced back. The beauty about hospice is that we go with your life goals is. But then 6 months after that, she came back on service and she passed away. But the beauty about grief is that we're gonna go right where you're at. Anger, denial, and there's gonna be a time where there's gonna be love and acceptance. And it all starts from day one. The benefit about having hospice is after you pass, then we have 13 more months of being available to you for support.
So what role does a social worker play on the hospice team?
Well, I'm there from day one with Nancy. My job is to educate you guys on who covers hospice, reassuring you that, are you listening to what the doctor said? Did the doctor inform you that they need hospice? Covering all the gamuts of how are you going to provide care? Is it moving into a boarding care? Is it hiring 24-hour care? Is it me gathering a meeting with a family so everyone takes shifts? My role as a social worker is to help with those beautiful goals, and it's also to help follow along with the nurse team to talk about end-of-life symptoms. We're working together in educating the family, okay, you're gonna watch that he's not breathing and it's gonna slow down. Changing of coloring. The nurses will say, Mary, we see him declining. My job is to help communicate that with the family and to provide support to them and help them listen. And help in that process. That's my goal, my role as a social worker.
Thank you. How does spiritual and cultural beliefs play a role with the hospice care?
Wow. There's 60 people here? Each and every one of us have a different story and a different background, spiritually and culturally. I know that my slideshow says, what does it say? And I don't like to categorize everyone, but I have to just a little bit. I feel that white Caucasian European families are much more educated in preparing for end of life. I see that families of color, and I'm only going to use my own family, I'm Filipino, we like to hold on, and we're still hoping for hope. We're still hoping that they're going to get treatment, unless we're educated enough to know that, okay, it's time for hospice. Our goal as a social worker and as a team is that we want to focus on where you're at. Every single one of us has a different story. Every single one of us has a different goal. Every single one of us come from a different cultural background. But the main goal for that is that we focus on where you're at and where you are spiritually. There is a spiritual component to hospice, in which we love having our chaplains come alongside of us, because no matter what faith or what religion or where you're at, we allow that process to happen, because some people always, even at the end of life, believe in some spiritual thing afterlife, right? But our goal as a social worker and as a team is to find out what your culture is, what your religion is, if you have one or not, and to help individualize each plan of care so we could meet your needs and provide comfort to you during that time. Okay.
What should someone expect the first few days of having hospice arrive?
A rush of people. So in the beginning, we're going to get a hospice order. Then what's going to happen is we're going to verify your insurance, and we'll talk about that later. Then you're going to get a social worker or a nurse who's going to come to you and talk to you about your benefits. And we're also going to see whether or not you're ready for hospice. Then you sign on to hospice. Then a nurse comes. Then a chaplain comes. No, the nurse comes. Then all your equipment comes. Then your medications are ordered. Then after that, all your supplies are gonna come. Then you're gonna get a hospice, the chaplain to come. Then we gotta get the bath aide to come. You're gonna get all that within 5 days. And we also have to make sure that you have care that's available.
So can you talk quickly about one moment in your work that reminded you of why this kind of care matters? Is that too long of a?
No,
Okay, that's quick.
I was ready for that question. Well, like I said earlier, I've been in the field for a long time. And I studied every theory you could possibly think of until my own mom died, and then my dad went on to hospice. Shortly after that, 6 months later, my brother died. 6 months after that, my aunt died.
Wow.
6 months later after that, my dog died. And then I got a divorce.
Oh.
So all that within less than 2.5 years brought me to a place of understanding what grief really means. When my dad and my mom were processing whether or not they wanted hospice or not, my mom went on it 3 times in 3 years. My dad was a wartime vet, so he pumped her chest and she got on a ventilator. The doctor at Palomar looked at us like, are you kidding? Well, I come from a big background of medical people, physicians, nurses, administrators. We all were not ready for hospice, but we did it and did it 3 times. Finally, when it came to my dad, we said we're going on to hospice. At that time, the doctor kicked us kids out because they wanted to ask him, what do you want? Do you want hospice? Because, well, I don't even know what my diagnosis is. My kids all just made this decision for me. So we got kicked out, he made the decision. The turning point of my life after all that grief, I realized I could be in the hospitals and try to and do a rehab, but what's meaning more to me is to be able to understand now what you're feeling, and my job and why I turned is because of my own story. That's why.
Thanks, Mary. I know Nancy talked a lot about what the care the costs are, but do you have additional information to share on that?
Yes, so private insurance, whether it's TRICARE for Life, Kaiser, Sharp, Medicare, everything reverts back to Medicare guidelines, and Medicare pays for hospice. The only thing that you'll have to pay for, including your medications, your equipment, your supplies, that's all covered under Medicare. However, anything that's not related to the diagnosis is a separate, can be billed to your secondary insurance, like the medications. Like if a person's on insulin, but they have cancer, it will be billed to the secondary insurance. The things that are not covered is a 24-hour care at home. Who's gonna help when that person needs to be changed? And a lot of times it can't be family because they're still grieving, or you're elderly and you can't do it. So you have to pay for out-of-pocket expenses, like a caregiver, a board and care, placement. A social worker can help you even tap into your VA resources. If you're a veteran, lead you to a realtor who can help you navigate, pulling in some equity, a reverse mortgage, things like that, to be able to help guide and provide 24-hour care. Your equipment is covered by underneath Medicare, which they need oxygen, a hospital bed, bedside commode, wheelchair. So all those things are covered underneath their Medicare benefit. But although you may have Kaiser and Sharp, as long as you're 65 years and older, all that benefit then reverts over to your Medicare benefit. And that covers hospice 100%.
Did we cover all the slides on financial before I go on to Janet?
Other financial stressors. Oh, that one part I do want to have you guys prepare for, other financial stressors, is it's good if you can start now figuring out who's gonna pay for the funeral expenses. That's really a big one, but a social worker can help you navigate that. Looking at how much the cost of 24-hour care would be, that's a big one. 2, aborted care or placement, and how much does that cost? Because all that is added expenses that you guys will have, but then the hospice will be the benefit that you guys get under Medicare.
Okay, thanks, Mary. Next, I'm going to talk to Janet on different end-of-life choices. So, Janet, what does California End-of-Life Option Act allow, and what are the current limitations?
So California End-of-Life Option Act allows medical aid and dying, which you'll hear me use the acronym MAID. Where a physician writes a prescription for lethal medications for those who qualify. You have to qualify. California is one of only 11 states, actually there's going to be a 12th because I think New York is going to pass their law. And then the jurisdiction of Washington, D.C. that we have such a law, so we're really lucky to live in California where we have this available. To qualify, you have to be a California resident. You have to be an adult, 18 years or older. You have to have the mental capacity to make your own healthcare decisions. You have to have a terminal illness with less than 6 months projected to live. And this has to be self-administered, which means it needs to be ingested, but the American Medical Association has defined ingestion as something that's introduced anywhere within the gastrointestinal tract. So for somebody who can't swallow any longer, it can be introduced through a feeding tube, or it can be introduced through a rectal tube. But the patient has to be able to push down this plunger on this, it's a 60 cc syringe, which is 2 ounces. That's the least amount of fluid of the medication. And that medication is thick, and it's really difficult. So they have to be able to completely independently do it, and nobody can help them. That's against the law. So, did you want to talk about for those who don't qualify?
Yeah,
or
for those who are
excluded?
eligible. Yeah, go ahead. Yeah.
So, as you can see, if you look at the last 3 requirements of the law, if you have dementia, you do not qualify for medical aid and dying. Because by the time you're within 6 months of dying, you are not going to you're not going to be of sound mind. So if you got a concurrent diagnosis of, say, pancreatic cancer, and you were still in the early to mid stages of dementia where you knew what you were asking for, then you could access it. But if you have a sole diagnosis of dementia, you will not be eligible for medical aid and dying. If you have a chronic, progressive, or debilitating disease that's causing you a lot of misery, but you're not within 6 months of dying, you will not qualify for medical aid and dying. For those who can't self-administer, so some patients with Parkinson's, MS, ALS, they're not able to have the strength, or they may not be able to swallow any longer, and they may not have the strength and coordination to push the plunger, so they may not qualify for medical aid and dying unless the doctor, there's some physicians that do some workarounds.
So for those who are eligible, what does the process of accessing medical aid and dying look like from the initial request to the actual medicine?
So you have to make 2 verbal requests to the prescribing physician that are at least 48 hours apart. And finding a prescribing physician can be a little tricky. It may not be, most likely it's not going to be your primary care provider. And on this form, which is over on the table that I was attending, on the back there's a way to find prescribing physicians. There are organizations that can help with that, and there are actually concierge physicians who provide that. And then you need a second physician, and that physician really just plays the role of saying that you meet the requirements of the law. You have a disease that's going to kill you in 6 months, you're of sound mind. And then there needs to be a written request, but it's not something that you write out. This is a state mandated form, and so you just fill out the form and you sign it, and it has to be witnessed by 2 people. Only one of those people can be a loved one who's going to inherit your estate. It's kind of important. You don't want 2 people saying, yeah, let it go. And then only one can be somebody that may be on hospice service that you're on. It can't be the attending physician or the prescribing physician. Next slide. So what is this medication? It's not a nice little pill that you just swallow. It's an ever-improving combination of about 5 different medications that are in powder form that are added to 2 to 4 ounces of fluid. Used to be a much larger volume, used to be 6 ounces of fluid, but this medication is bitter. It does not taste good. It also can burn the esophagus. And so most providers will have somebody have some sorbet or suck on a popsicle first to kind of numb the esophagus and take that taste away. And so for those who know medications, the first 2 that are listed, phenobarbital and diazepam, are sedatives, so you fall asleep. You have to drink this medication in 2 minutes because you will start to get drowsy. Digoxin is a cardiac medication, but in a really large dose, it's cardiotoxic. And morphine is an opioid, so another sedative. And amitriptyline is one that they've in the last couple of years they've added. It elevates the heart rate. It's actually an antidepressant, but the side effect is it elevates the heart rate. And what they were finding is as they brought people's oxygen level down with all the sedation, and the heart rate came down too. That takes longer to die. So if they increase the heart rate when they're bringing down the oxygen, people die faster. There's a pre-medication that people take to prevent nausea and vomiting. Take about 30 to 60 minutes before you take the lethal medications. Once this is ingested, unconsciousness generally happens in about 5 to 10 minutes, with death occurring on average in 30 to 60 minutes, but it can take much longer. And especially for people who have poor absorption in their gastrointestinal tract, it can take hours. There are people that take 10, 14 hours to die. So had my husband have done that, he would have been one of those people that took a long time to die. Next slide, please. So some other interesting facts I think about medical aid in dying are that it costs about $700 to $800. It's not covered by a lot of insurances. It's not covered by Medicare. It's not covered by the VA hospital because those are federally funded insurance programs for now. But it is covered by Kaiser and Medi-Cal. Utilizing medical aid in dying does not disqualify somebody from their life insurance benefit. This is not suicide, this is medical aid in dying. And the cause of death on the death certificates, the underlying disease process. And nowhere on there does it say that the person utilized medical aid in dying.
With individuals who are seeking more control and autonomy at the end of life, what are some options that people turn to when they're not eligible for medical aid in dying?
So probably the most prevalent is voluntarily stopping eating and drinking, or VSED. And in this process, you take in no food, you take in no fluids, which is the most important because you're basically dehydrating yourself to death. There's no law against this. We can refuse anything. We can refuse chemo, we can refuse dialysis, we can refuse to eat and drink. Death generally occurs in about 7 to 10 or 14 days. And typically people will, first day they're hungry, second, third day they're very thirsty. Then people start to get kind of confused and weak, and then you'll lapse into a coma and eventually die. You have to have assistance to do this process. It is an arduous process. You need a support team, either filled with loved ones or paid caregivers that will be there with you until the time that you die. And you need some medical personnel because you may have some agitation or anxiety, and so it's good to have some meds on board just to help with that. So Final Exit Network is a nationwide organization, and they provide free exit guides who are just volunteers that come in pair. And they talk you through the process of using an inert gas, nitrogen, to peacefully end your life. You don't have to be terminal, but you do have to qualify for this. And so if you have, a constellation of problems, you have diabetes and you've had an amputation, you're losing your vision and your kidneys are shutting down, then you qualify. If you're in the early to mid stages of dementia, you can qualify for Final Exit Network. So the first step is to provide a written request saying why you want to hasten your death, and then also providing pertinent medical records that shows your medical issues and what you've tried. This is the important part, is that the volunteers can tell you how to do this process, and they can help you get everything set up, but you have to independently be able to purchase the equipment, which is a small tank of nitrogen, a regulator that goes on that tank, that then connects to tubing that goes to a plastic bag that you put over your head. And people usually gasp at that, but the bag stays filled. Once you start the flow of nitrogen, the bag stays filled. It never goes, against your face. It's clear. You can see through it. The equipment costs about $300. So they can tell you about it. They cannot assist you in any way. You have to be able to do all of this yourself. This method is quick. People are unconscious in 30 seconds to 60 seconds and die generally within 8 to 10 minutes. It's reliable and it's peaceful. It's my method of choice. I have my nitrogen tank at home whenever that day may come, this would be my choice. But it can take several weeks to get through the process. So these are things you don't do instantaneously. These are things you plan for. Okay. So another option for those who can afford is to go to Switzerland. So Switzerland is the only country in the world that allows what they call voluntarily assisted death for people who aren't residents of Switzerland. So there are three main organizations. There's Dignitas, and they see roughly 40 Americans a year. Pegasus, and this is Athanasius is a brand new one that just opened in March, so I know less about them. But those are the organizations that people from all over the world can go to. Next slide, please. Oh, you're already there. So what you need to be able to do this is you have to have a passport, of course, because you're traveling to Switzerland. You have to have proof of residence, where you're coming from. They want to know what country you're coming from. You have to have the long form of your birth certificate that's been reissued and certified within 6 months of when you're going to voluntarily assist or end your life. And that's not difficult to get. You can get these online. And if you're married, you need a marriage certificate. If you've been divorced, you need the divorce certificate. If you're widowed, you need your spouse's death certificate. You have to provide the medical records, proving that you know what your diagnoses are and that what treatments you've attempted. You have to have a psychiatric evaluation to prove mental competency. And this roughly costs, just the process costs about $11,000 US. And people gasp at that too, but I have a dear friend who accompanied her mom. Her mom had just gone into a memory care unit, but she still was pretty competent. And for all of her sisters to go, her to go, them to go, all of their every expense that they could possibly incur cost $20,000. She said, Janet, that's 2 months in a memory care unit. My mom was otherwise healthy. She had a good heart. She had good kidneys. And so she said, people say that's so expensive, but it would have been much more expensive had she have died naturally with her Alzheimer's. So this can take a couple of months to get this set up. So again, you need to approach those organizations early.
So many families struggle with having that conversation about end-of-life preferences, especially when beliefs differ. What helps these conversations become more open and compassionate?
So first, I just want to say that we should start these conversations early. Okay, I'm 68 years old. I'm in very good health, I think. But my entire family and my loved ones know exactly what I want. They know I've got a nitrogen tank sitting in my garage. They know my powers of attorney for healthcare know exactly what they need to do if I'm not making my decisions. Make sure that you don't provide me any fluids. Don't let anybody hydrate me. So start these conversations early, so it doesn't get to where now all of a sudden you're not feeling well, you're sick, and now you have to have these difficult conversations. Then it's not a surprise. We're so death phobic in this country, and we need to openly talk about death. We plan every other aspect of our life. Pick a convenient time for all where you're not going to be interrupted or disturbed. because these are difficult conversations. I recommend you start from a place of love. You're doing this as a gift for your loved ones so that they know what your wants and desires are. And that, you know, this is important to you. You want them to know this because if you fall sick quickly and they're unsure of what you want, you've just added on to their grief and misery a whole nother dimension of what do you think it is mom wants? What should we do? You went through, like you went through.
It was not easy.
Yeah, and so, and I would emphasize that these are your desires and they're your values and that they may not be the same as yours, you know, the person you're talking to, but they need to hear what it is you want and they need to respect it and you need to make sure you've got it in advance directives so that they know. And if you need, you can consider having somebody facilitate these conversations. So Nancy over here is a death doula as well. And death doulas, there's a lot of death doulas in our area, and they will help facilitate these difficult conversations with loved ones. You could use clergy, or I have people who call on me because I worked in this world a lot, and so they'll say, Gianna, please come when I want to talk to my son. Will you please come? And in addition to talking to your loved ones, make sure that your primary care physician knows your wants, and make sure that if you're seeing specialty doctors, a cardiologist, you know, a pulmonologist, that they know what your wishes are as your life comes to an end.
So one last quick question. How can someone learn about end-of-life choices while ensuring to get accurate legal and ethical information?
So for the widest array of information on the end of life, I would go to Hemlock Society of San Diego. They'll talk about anything. We do one-on-one counseling with people as far as questions. You can call, email us. If you're looking to really utilize medical aid in dying or voluntarily stopping eating and drinking, End of Life Choices California is an excellent organization that will assist with that. Not only helping you find a providing physician, but getting you through the process and having a bedside presence through whichever those two processes. Empowered Endings and Autonomy Health are two concierge physician groups that do end-of-life medicine. They're excellent. And the Academy of Aid in Dying Medicine also has a portal on their website where you can find a prescribing physician if you're having difficulty with that. The VSED handbook is really a great handbook if you're going to utilize VSED. It's sort of like a recipe of everything that you need to get through that arduous process. And if you're looking for an advanced directive, Final Exodus is a great website that has advanced directives and really talks you through that. And Compassion Choices has a particularly good dementia directive on theirs that you can find under a resource tab for dementia values and priorities tools.
So I'm going to invite the panelists to step off right now. I have a couple important announcements to make. They'll be here afterwards. I'm sorry we didn't have time for Q&As, but I thought it's really important that you hear all the information they have. Let's give them a hand.